Welcome to Introduction to Anatomy. My name's Joanna. I'm one of the anatomy lecturers here. So before we start, I'd like to mention some recommended texts. For general anatomy, we recommend Moore, Egger and Daly's Essential Clinical Anatomy. I'd also recommend that you have an anatomy atlas. We recommend Netter's Atlas of Human Anatomy. And for neuro, which I will mention in a separate lecture, Crossman and Neary's Neuroanatomy is the recommended text here. Now, I've requested that the library acquire the ebook versions of these. However, if you already have an anatomy text, an atlas or a neuroanatomy text that you're happy with, that's fine. You don't have to have these particular texts. All anatomy is the same, regardless of what textbook you read. These are just the ones that we recommend and that we ensure the library has access to. But please don't worry if you have a student Gray's or Snell's anatomy. They're all fine. So we have some UL specific e-learning resources. Sulis is probably going to be your first port of call for most things. So all lecture notes will be added onto Sulis, as well as the accompanying video. Any announcements like changes in timetable and things like that will be put up on Sulis. We might add module assignments, quizzes, things for revision on there. So it's important that you check your UL email regularly. We also have access to Ackland's videos. These are amazing dissection videos. They can be found through the UL website under the Graduate Entry Medical School link. And another good resource for gross anatomy is Teach Me Anatomy, the link for which is here, teachmeanatomy.info. So there are other resources that UL students have access to, however many of these will be restricted due to the current situation. But when normal university life resumes, it is possible to book the anatomy lab and to make use of the models and things that are located within there for any self-directed, either individual or group learning that you wish to do. This is all managed by the technical team, so you can contact them at this email address, School of Allied Health technicians@ul.ie. It's also possible to view any past papers via the UL SharePoint website here. So these are the learning objectives and the topics that are going to be discussed during this session. All this information can be found in the introductory chapter of any anatomy textbook. So I recommended Essential Clinical Anatomy, but pretty much any anatomy textbook, the first chapter will cover pretty much all of these themes. These are all essentially the fundamentals of anatomy, and also kind of moving on to some of the basics of, more specifically, MSK anatomy. So first things first, what is anatomy? So it's the study of the structure of organisms and their parts. The word anatomy comes from the Greek to cut up or to cut apart, just like you would during a dissection, from which all anatomical knowledge has come about. So even as far back as like the 16th century and beforehand, we can see here this image from Andreas Vesalius's De Humani Corporis Fabrica text, one of the most influential anatomy texts of its time. It's depicting a dissection. You can see the cadaver here on the table, and we have the anatomist, who is Vesalius himself, the great anatomist, and all these people. So public dissection used to be the order of the day back then. It's not quite the same anymore. It's not the same at all. It's all very private and highly regulated now. So, and actually, other than me using some cadaveric images in your lectures, that's as close as you're going to get to a cadaver, so you don't need to actually worry. You won't be doing any dissection during your time studying anatomy here, unfortunately. So it's also important to note that there are different branches of anatomy. So of course, anatomy covers gross anatomy, thinking about regions, the upper limb, the lower limb, the abdomen, or the systemic anatomy, so the digestive tract, the cardiovascular system, the musculoskeletal system. But anatomy actually is like an umbrella term that includes many different areas. So we also think about histology, so the structure of the tissues that make up the organs and parts of the body. Also embryology, so the development of the human body. Very important for you would be surface anatomy. You don't unfortunately get to go at your patients with a scalpel to have a look what's going on beneath the skin. You have to have an idea just by looking and palpating your patient. And then also functional anatomy, which it's important to make the distinction here between functional anatomy and physiology. They are not the same thing. Essentially, functional anatomy is how the structure of the body is fit for the function that it has. So you might think about how muscle fibers are orientated with relation to each other, and therefore how are they going to contract? Or maybe the shape of articular surfaces of bones to allow the proper movement of a joint, and how that then affects the types of movement that can happen at that particular joint. So that's functional anatomy. What can be a very difficult part of anatomy is actually learning the language of anatomy. It essentially has its own language, and you must become comfortable with this language. It's used the world over in healthcare. So most anatomical words have either a Latin or Greek origin, mostly Latin. Developmental words and words associated with embryology tend to be more on the Greek side, but that's just a general rule. There are, of course, exceptions. So unfortunately, learning anatomy can sometimes be seen as akin to learning a new language, and that's just the nature of the game, I'm afraid. So we'll start thinking about the language of anatomy and start trying to get it into your mind. So on this image we see the regions of the anterior side of the body. So we're looking at the front of our chap here, of our model, and over time all of these terms will become completely second nature to you, and I'm actually sure that many terms will already be familiar with you, to you, such as the cervical region for the neck, axillary region, talking about the armpit, umbilical region for around the belly button or navel area. These are, these are all things that are in normal speech, but all of these are terms that you should be aware of. Thinking about things to do with the wrist, are called carpal. Things to do with the leg being the region between the knee and the ankle, as opposed to the whole lower limb when we're talking about anatomy. So the leg, or things related to the leg, tend to be crural, described as crural. Things to do with the groin, inguinal, things like that. So these are all terms that over time you should become familiar with. And then this is the same sort of thing, just looking from the posterior view this time, so the back of our model. Some other regions. So when we're referring to the position or the relationship of anything in anatomy, we tend to do this using an anatomical constant, and this is known as the anatomical position. So we can see a perfect demonstration here on this cartoon image. So this position is defined as being upright or erect, facing forward or anterior, arms by the side with the palms facing forward, feet together, head up, eyes looking straight forward. That is the anatomical position. And this is so important because obviously the body can change orientation with respect to the environment, and then the limbs are able to change position with respect to the trunk. So in anatomy, for descriptive purposes, we use this standardized position as a reference point, and it always goes back to this reference point. And so once you have this standardized position, you have this reference point, we can now add in some anatomical terms which relate to body positions, such as, so we've mentioned anterior, which is towards the front of the body. Another word for that is ventral. This is sort of an older word. You can use either. Anterior is probably more modern. Ventral tends to come up again when we're talking about development and embryology. We still tend to refer to things as ventral. But for the purposes of your studies in anatomy, I'd probably use anterior. And then posterior is the opposite. It's the back side of the body, towards the back. It can also be referred to as dorsal. Again, this is like the older term for posterior. They mean the same. We then have superior, which means towards the top or towards the head. And then inferior, the opposite, towards the bottom, towards the floor. There's then proximal and distal. Now these are kind of similar and often actually confused with superior and inferior. So we tend to use these quite often when we're referring to the limbs. So obviously limbs are able to move with reference to the trunk. So they can move out of anatomical position. So proximal means towards the trunk, and distal means away from the trunk. So it doesn't matter where your arm or your upper limb or your lower limb are placed in space, proximal and distal will always be the same. Your fingers will always be distal to your shoulder, even if your arm is up above your head. Whereas when we use the terms superior and inferior, when we're studying anatomical position, our shoulder is superior to our fingers. However, if we were then to move out of anatomical position and now our hand was above our head, for example, now our fingers would be superior to the shoulder, if that makes sense. So proximal and distal are just a way of referring to particularly limbs. They are used in other regions like the gut and things like that, but essentially they're particularly important when we're referring to limbs and the movement of limbs. Some other important terms that you should become aware of and bring into your everyday vocabulary is medial. Medial means towards the midline, and lateral. They're not very easy to see on this image, I'm afraid, which is the opposite and means away from the midline. So you might say that your trunk is medial to your upper limb, or your left hand is lateral to your belly button, or your ear is lateral to your nose. Now, some other positions of the body. When you lay on your tummy, like this fellow who's having a snooze, this person is in the prone position. When you're lying on your back, you're in the supine position. These are positions that you may well ask patients to lie in throughout your studies and throughout your career, so you can access certain regions of the body more easily. And when we're referring to, say, injuries or symptoms or anything related to the body really that is occurring on one side of the body, we'd use the term unilateral. And if it was both sides or happening on both sides, we'd say it's bilateral. So if something's happening on the same side of the body, we refer to that as ipsilateral. So, for example, the person on our image here has a highlighted upper limb on the right hand side, and the ipsilateral lower limb is also highlighted. Contralateral, on the other hand, is the complete opposite. So this time we have a highlighted left upper limb, and it's the contralateral lower limb that is highlighted on this image. So those are terms of laterality. When it comes to movements of the body, there are many terms that we need you to be familiar with. Terms like flexion, extension, abduction, moving the arm away from the body, or the limb away from the body, adduction, moving it back towards the body, rotation, and even more region-specific terms such as opposition and reposition of the thumb, or say inversion and eversion of the foot. So these are all the types of terms that we'll come across when we start looking at MSK anatomy in more detail. Next, we're going to talk about the planes of the body. So there are three main planes of section that we'll be constantly referring to during your studies. So the first one is the transverse plane. This is shown on this cartoon here. So this is a cut separating the top from the bottom. So this is an MRI image through the knee. So what we're looking at here are the femoral condyles of the femur here, and everything below the whole of the leg, ankle and foot have been cut away on this image. Next is the coronal plane, or frontal plane is another term for it. This refers to cutting the body front or anterior from the back, or posterior. So cutting front from back. And we can see here on this CT scan of the abdomen, essentially the posterior abdominal wall here, we can see the vertebral column here, and some muscles associated with the vertebral column that you'll come across later on. The hip joint here on the right hand side, and the hip joint on the left hand side. So essentially everything that lies anterior to these structures has been cut away, and we're left seeing a cut through the posterior part of the body. And then thirdly is the sagittal plane. So this refers to cutting the body left from right. So this can either be in a median sagittal way, or the cut is in the midline of the body, so you're cutting directly in the middle between left and right. Or it can be paracentrally, so this means moving laterally either left or right away from the median plane. So at this point, I'm going to ask you to pause the video, and I want you to try and have a go at determining which anatomical planes are which based on the images on this slide. You can also use this time, if you want, as an opportunity to practice some of the other terms that we've mentioned, things like anterior, posterior, superior, proximal, all of those. So pause the video and have a little go. Now, an absolutely crucial concept in anatomy is that of anatomical variation. Generally speaking, we're all made up of the same kit, and it's all in the same pattern. So for example, we tend to have one head, we tend to have two eyes, one nose, one mouth. That kind of way. We all have that, or generally we all have that same pattern. Of course, there are always exceptions. But we don't look identical to one another, do we? So there have to be subtle differences that allow us to be individual and not to all look identical to one another. So this is the same when we delve kind of beneath the skin and think about our anatomy. So there's a general pattern that is followed by almost all, a typical pattern, you might say. But then some individuals, including yourself, myself, will have subtle or sometimes quite profound differences. They work in exactly the same way. They don't cause problems necessarily, but there are slight differences. So take, for example, this is an absolutely classic example of anatomical variation. So we're looking at this is the same person on the image here. On the right, if we just look at the wrist, on the right wrist, we can see a tendon protruding across the wrist here. This is the palmaris longus tendon. So if we look at the left hand, or the left wrist, we don't see a palmaris longus. So this person has a muscle and a tendon on the right side of their body, but not on the left side of the body. That's anatomical variation. That's anatomical variation within an individual. So their two upper limbs are slightly different from one another. It doesn't affect them. Palmaris longus isn't a particularly important muscle anymore. and it's actually absent in up to about 20% of the population. But it's a really good demonstration of anatomical variation. So, as I say, up to 20% of the human population, palmaris longus will be completely absent, and then you can have a situation like this individual where they have one palmaris longus on one side, but the other side doesn't have one, or you could have a palmaris longus on both sides. So why don't you look for yourself? If you place your thumb and your little finger together and then slightly flex your wrist, put a bit of tension on your wrist as you flex it. If you see a very slender bulge, tendinous bulge that sticks out, you have a palmaris longus. If you don't, it's no problem, but there we go, you have an anatomical variation. I myself have on the right, similar to this individual here, I have a very obvious one on the right hand side, and then on the left hand side it's not quite so prominent, but it's still there. So I do have two. Another common anatomical variation happens in the heart, and this is all to do with the origin of the coronary arteries. So usually the coronary arteries arise from two of the three cusps that make up the aortic valve at the top of the heart. However, as we can see depicted in this image, there are so many different ways that coronary arteries can be arranged from their origin on the aorta. And the vast majority of these wouldn't cause any problems. You wouldn't have any idea that this was the case. You'd go on, you'd live your life, and you'd be none the wiser. Unless an anatomist like myself came along and dissected your heart and thought, oh, this is interesting. Look, they only have one coronary artery, or the coronary arteries come from in a different way. That's it. But anyway, that is anatomical variation. It's a really important concept that you have to appreciate, particularly when you're going into a healthcare field. Patients are individuals. They will have generally the same patterns, but there could be slight differences that might affect the way you treat them down the line. We're now going to move on from terminology and discuss briefly the structural organisation of the body, from cells through to systems. So first up, cells. Without cells, we wouldn't exist. They are essentially the building blocks of the entire body, all the tissues and organs in the whole human body, whether it be, say, myocytes or muscle cells, neurons of the nervous system, osteocytes, also known as bone cells, or blood cells, any type of cells. And they all play hugely important roles, both individually and also together, to maintain a nice healthy body. So the cells, whatever cell type they are organised into tissues. And there are four main tissue types that we're going to look at anyway. These are epithelial tissue, as we can see here in the top left hand corner. So things you find epithelium in lining body cavities, in the skin, lining blood vessels, lining the digestive tract. You find epithelial cells and epithelial tissue, should I say, throughout the body. Nervous system, I think, speaks for itself. This includes the neurons and all of the other cells that are related to the nervous system. Again, rather self-explanatory is muscle tissue. made up of muscle cells. There are different types of muscle tissue that are found in different parts of the body, and that all have different roles within the body. And then finally there is connective tissue. So bone, cartilage, stuff like that are all classed as connective tissues. So tissues then come together and they form organs. So tissues that have similar functions tend to work together in the same way, forming an organ. And then once we have organs, we can make systems, because you'll have organs that work together to perform a certain type of bodily function. So the cardiovascular system, for example, we have the heart and we have all the blood vessels. So they are all different tissues and organs that work together to form that system. The digestive system, you have your everything from your teeth and your tongue, your esophagus, your stomach, all the way through your gut, etc., etc. So there's a list here of many of the systems of the body. This is not them all, but they are systems that you're going to come across during your studies. So the following slides give examples of different types of epithelial and connective tissues. From here, we're then going to move into a deeper sort of exploration of the skeletal and muscular systems. So an in-depth knowledge of epithelial tissue isn't necessary, but certainly an understanding of where different types of epithelial tissue are found, and that they have different functions, is useful. Now, there are many types of connective tissue. We have things like fat and fascia, things that we'll come across down the line, classed as loose connective tissues. We then have dense connective tissues, which you will come across many, many times, because they form things like tendons and ligaments. And then specialist connective tissues, which form your cartilage, your bone, and the different types of bone, the different types of cartilage, and even down to blood. So whilst we're on that, think about what or which type of connective tissue make up these structures shown on these images. Tendons, this is a flat tendon here, plantar aponeurosis. Still a tendon, it's just not a round cord. And here we have some ligaments of the knee. Do you remember which type or which category of cartilage they would come under? Not cartilage, oh, for God's sake. Can you remember which type of connective tissue these come under? Now, fascia is an interesting one, and I'm only going to mention it very briefly, but we will discuss fascia from time to time when we're talking, particularly when we're talking about musculoskeletal anatomy. So it's a type of connective tissue, loose connective tissue, and it wraps itself around muscles, and it also forms thicker kind of septums or septa that lie between muscle groups. And we can see here on this image, this is a transverse section through a thigh. And we can see that there are groups, or there are individual muscles separated by all of this like thin white stuff. So that's fascia. And then I think it's quite obvious that this is anterior here and this is posterior. And we can see that we have an anterior group that seems completely cut off from everything behind it. So then actually we have a posterior group here, and we have a medial group. But for argument's sake, we can see an anterior group very distinct from everything behind it. Now, cartilage. We will talk about cartilage a lot, again, when we're looking at musculoskeletal anatomy. So things that are related to cartilage have the prefix chondro. For example, the cells that make up cartilage are called chondrocytes. Chondro for cartilage, cyte for cell. So there are 3 types of cartilage that you should be aware of. The one you will come across probably most, possibly every day of your anatomical endeavour, will be hyaline cartilage. So hyaline cartilage is the type of cartilage that covers articular surfaces at joints. So you'll find it in the elbow joint, the shoulder joint, the wrist joint, all of the joints in the hand and fingers, in the knee joint, the ankle joint, you name it. You'll find it in all of those kind of joints. It also forms your costal cartilages, or the cartilaginous part of your ribs. So your ribs aren't all bone. Anteriorly, they are formed of cartilage. This is hyaline cartilage. And also you'll find hyaline cartilage in your nose. And a few other places, but that's enough for now. The next type of cartilage to be aware of is fibrocartilage. So there are some really important places where we find fibrocartilage, like the intervertebral discs. So you'll come across those a lot when you're doing vertebral column, back pain, all sorts of things like that. Also in the pubic symphysis. Pubic symphysis is the joint at the anterior side of your pelvis, connecting the right and left hip bones together anteriorly. We'll also find it in the menisci of the knee. So those pads that lie within the knee joint are also formed of fibrocartilage. And then the third and final type is elastic cartilage, and this is found in the ear and the epiglottis. Moving on to bone-associated structures, which have the prefix osteo, such as bone cells or osteocytes, or the precursors of bone cells, which are known as osteoblasts. These form the bone matrix that will become the osteocyte. Or bone stem cells, osteogenic cells, or those cells that resorb bone, known as osteoclasts. So bone can be subdivided into spongy bone, also known as trabecular bone. This is a really porous or trabeculated bone type, as we can see here on this coronal section of the femur. There are large holes. It essentially looks like a sponge, hence the name. And then we have compact bone. So compact bone is denser, much denser than trabecular bone. So it's much heavier. And this is the type of bone we see around the outside of the same section of femur here. Now, obviously, bone needs to be really strong because it has to support our weight. But it also needs to be able to move and do some other physiological functions. So to have a complete skeleton of compact bone would be horrendous. So essentially, both these types of bone, spongy bone or trabeculated bone, and compact bone are absolutely essential for the correct working of the skeletal system. So we'll now discuss the skeletal system itself. The skeleton provides support for the rest of the body. It's also the reason we can move. There are joints that, when muscles are attached to those joints, allow us to bring about movement. And I also mentioned that it also has some physiological functions. For anatomical descriptive purposes, though, the skeleton is divided into two regions. We have the axial skeleton, which contains the head, neck, and vertebral column as a whole, and the ribs. And then we have the appendicular skeleton, which contains the bones of the upper limb, the bones of the lower limb, and the pelvic and pectoral girdles that are connecting the limbs to the axial skeleton. Now, each of the bones of the skeleton can actually be classified by its shape. So we have flat bones. We tend to find those in the head, in the vault of the skull surrounding your brain. Bones like your frontal bone, your parietal bone. We also have long bones. Long bones are found mainly in your limbs. Ribs are also long bones. So an example here is the femur, the longest bone. We have short bones as well. Bones like the carpals of your wrist are known as short bones. We also have irregular bones. They have an irregular shape. They look a little bit funny, as opposed to a long bone that looks like, if you ever conjured up an image of a bone in your mind, you probably have a long bone in your head. But irregular bones don't fit this format. So vertebrae, for example, would be irregular bones. There are also a few strange types of bone. We have sesamoid bones, such as the patella. There aren't many of these throughout the body, but they're a special type of bone that is kind of wrapped up in tendon. And then there are others, such as sutural bones or wormian, that we find within the joints of the skull, or sutures of the skull, hence their name, sutural bones. They're like little islands that develop within these joints between the skull bones. So as we start to further investigate individual bones, we'll notice that they have features and so-called bony markings. And these can be used as landmarks from the surface. So surface anatomy in many, many instances. So essentially what we're doing here is adding more and more words to your anatomical vocabulary. So features like holes are no longer called holes. They might be called foramina, or they might be called meatuses, or sinuses. Bumps on bone or little projections that you see on bone are not called bumps or projections. They're called tuberosities or trochanters or tubercles or spines, or there are lots and lots of different words that essentially mean the same thing, but it all depends on the size of this particular projection, if you will, and its position within the body. It's important to note that bones are extremely vascular organs. So in this first image here, we can see the development of a long bone in this example from its cartilaginous origin or cartilaginous template. So when a long bone acquires a blood supply, as we can see here in image D, it kickstarts a process known as ossification. So this is essentially how a bone develops. So in our long bone example, this first happens in the shaft of the bone, or the diaphysis. So this is known as a primary ossification centre. A blood supply will then enter into the ends of the bone, known as the epiphyses, and this will be the secondary ossification centre. So the junction between these two centres is vital for all growth and any further development of the skeleton throughout your childhood and adolescence until the skeleton reaches its final size, if you will. Then in an adult bone, which we can see in this image here, that area between the diaphysis and the epiphysis, which when bones are growing we call the growth plate, this area now just leaves behind a very thin line known as the epiphyseal line. So you might see that on bones from time to time. But those areas where we had the primary and the secondary ossification sites are still entrance and exit points for blood vessels. So we have nutrient arteries and veins which enter and leave the bone throughout life. So moving on to joints now. So wherever two or more bones unite, we have joints or articulations. So there are several classifications of joints, and we're going to, as briefly as possible, mention them now. So the first classification are fibrous joints. So here the articulating bones are connected by fibrous tissue, as the name suggests. So they hold the bones together very tightly, and so these type of joints actually have very little or no movement allowed. So we find these kind of joints in the vault of the skull. So here we call them sutures. I mentioned them before, so you can see this fibrous joint lying between the two plates of, this is parietal bone, and there's the other parietal bone, and the joint between them, the suture between them. We also see them fixing teeth into the jaw bones, so whether it be the mandible here or the maxilla above, and we call these gomphoses. Again, they don't allow much, if any, movement. We definitely don't want a lot of movement of our teeth. I think you would agree. We even have examples of fibrous joints in the lower limb. So there's one in the leg between the tibia and the fibula, known as the inferior tibiofibular joint. So there's a few examples, and throughout your studies you'll come across some of those again. Now, the second classification of joints are cartilaginous, and we have either primary cartilaginous or secondary cartilaginous subdivisions within this classification. So a primary cartilaginous joint unites a bone, or unites two bones or parts of bone, with a plate of hyaline cartilage. We can see that here. So this is the epiphysis of a long bone, and this is the diaphysis of a long bone. And this growth plate that we mentioned is actually an example of a primary cartilaginous joint. So it's a plate of hyaline cartilage which remains for the entire period that you are growing, and then once you've finished growing, it's obliterated. The hyaline cartilage completely disappears and is completely taken over by bone. And we can see that. We can see that on this X-ray as well here. So this is the diaphysis of the femur. This is the epiphysis of the femur, and the line between them is the growth plate or the epiphyseal plate. And the epiphyseal plate is a primary cartilaginous joint. The same can be seen on the tibia here, epiphysis, the diaphysis and the growth plate between, and even on the fibula here, there's the epiphysis, there's the diaphysis, and the line between is a primary cartilaginous joint. It's the growth plate. Then the second subdivision of cartilaginous joint are secondary cartilaginous joints. So these unite bones with a plate of fibrocartilage, and actually the articular ends of the articulating bones have a very thin covering of hyaline cartilage, but then between those two articular ends you have this plate of fibrocartilage. So an example of this would be the pubic symphysis. We can see that highlighted on the image here. So here is the right pubic bone, here is the left pubic bone, and sitting in between it, right there, is the pubic symphysis. Other examples are found between the vertebral bodies in the spine, so the intervertebral discs, and they allow a little bit of movement. Not a huge amount, but a little bit. And then our third classification joints, we're going to go into a huge amount of depth into examples of these throughout the body during your course. So this is just a brief overview of what is a synovial joint. So synovial joints are actually characterized by having a thin layer of hyaline cartilage, also known as articular cartilage, over the articulating ends of each of the bones involved in the joint. And then these articulating ends are separated by a joint cavity, which is in turn lined by a very thin synovial membrane, which extends from the margin of one articular surface to the other articular surface. They then tend to be reinforced by a joint capsule, so you tend to have some sort of articular capsule surrounding the synovial membrane. And then our articulating surfaces are then lubricated by a really small amount of a viscous fluid known as synovial fluid. So you'd find that within the joint cavity. And synovial fluid is actually produced by the cells of the synovial membrane. So this will have a turnover. So these types of joints, synovial joints, allow varying amounts of movement. Some are highly movable and some only move a small amount. And this movement is limited either by the shape of the articulating bones involved or by external features as well, such as ligaments and things like that. So we can now further subdivide synovial joints according to either their shape or the arrangement of these articular surfaces. So this image here shows examples of the kind of subdivisions of synovial joints and gives an example of a location of that type of synovial joint. So the first one I'm going to mention can be seen here, and we call this a plane joint. So the articular surfaces tend to be flat, or more or less flat, and so the bones are able to kind of slide against each other. So a nice example of this would be the acromioclavicular joint, which is being highlighted here. So there's the clavicle, and there's the acromion process of the scapula, and the joint between it is a plane synovial joint. The ends of the lateral end of the clavicle and the articulating end of the acromion process are relatively flat, and so they produce this kind of sliding motion. The next subtype I'm going to mention is shown here, and this is a hinge joint. So it's similar to a hinge on a door. So you can kind of flex and extend these types of joints. So the example shown here, typical sort of hinge joint between the radius, So the second subdivision of synovial joint we're going to mention is this one. It's a hinge joint, just like a hinge on a door. It permits flexion and extension. There are exceptions and slight modifications to hinge joints in certain areas of the body, but essentially it allows flexion and extension. And a nice example is shown here at the elbow, between the proximal end of the ulna and the distal end of the humerus. Then I'm going to have a look at pivot joints. So here we tend to have a central kind of bony pivot that's surrounded by some sort of usually bony or ligamentous structure and allows rotation. So a perfect example of this would be our atlantoaxial joint of the neck. So the first cervical vertebra, articulates with the second cervical vertebra around a pivot joint. Next up, let's say this one here. So these are ellipsoid or condyloid joints. They're quite similar. So essentially they have a concave surface and a convex surface, and they're elliptical in shape. So an example would be at your metacarpophalangeal joints. So those of your knuckle, have a look at your knuckle, and then you have a nice example of an ellipsoid joint. They allow quite a bit of movement, so you get your flexion extension. You also will allow abduction, adduction. And then we have saddle joints here. So here we have kind of articular surfaces that are both kind of concave and convex, and they sort of fit together like a saddle would on a horse's back, hence the name. So again, these are usually highly movable joints. They're going to allow flexion, extension, abduction, adduction, and rotation. And I think the best example is probably what is shown here. In the thumb, it's the carpo-metacarpal joint of the thumb, or the first carpo-metacarpal joint. And then finally, we have ball and socket joints. So here we have a ball-like articular surface that fits into a socket-like articular surface. These names are not particularly inventive. They do the job. So these tend to be freely movable joints. They will be restricted. The amount of movement will be restricted by external features like ligaments and things like that. But the joint itself is highly movable, so you can get your flexion, your extension, your abduction, adduction, rotation. You can do whatever you want. Different types of rotation, lateral rotation, medial rotation. You can put them all together and do circumduction. So think about your shoulder joint, and then think about the way you can swing your arm round in a circle. Or the example that's shown on this image is the hip joint. Again, you can do wondrous movements with your with your lower limb about the hip. So we're now going to take a quick look at the muscular system, and then we can call it a day. I'm sure you're all thrilled that we're nearly at the end. So we have 3 types of muscle. There are different muscle cells, and we have 3 types of them that make up 3 different types of muscle. So we have skeletal muscle, and we're going to go into more detail about this in a second, because this is what we're going to be discussing mostly during your studies. So skeletal muscle is striped in appearance and essentially is every muscle you know of. Your biceps brachii, your quadriceps muscles, all of those. We also have cardiac muscle. This looks similar to skeletal muscle in that it is kind of stripy in appearance, but it is solely found in the heart, and it's highly specialised. And then we have smooth muscle. Smooth muscle is completely different to both cardiac and skeletal muscle. It isn't striped, for one. It's completely involuntary. So you might call skeletal muscle voluntary muscle. It's fine to call it that. And you might call smooth muscle involuntary muscle. And you find it in like your gut, your bladder, things like that. Things that you're not under conscious control of. So I'm going to stick with skeletal muscle now. So as we say, skeletal muscle is voluntary muscle, and it has these kind of striped muscle cells or myocytes and muscle fibers. So skeletal muscles always have 2 or more attachments. We can either refer to these as proximal and distal attachments, or we can call them origins and insertions. I don't mind which terms you use. Anatomical vocabulary is bonkers. We have lots of different terms to describe the same thing. So I'm happy for you to choose whichever you're more comfortable with and stick with that. But just so you realise that calling muscle attachments origins and insertions, or proximal and distal attachments are interchangeable. I tend to use proximal and distal attachments. The reason being, so generally speaking, origins tend to permit relatively less movement, whereas insertions are the complete opposite and permit relatively more movement. However, there are exceptions, and sometimes this can be interchangeable, so I think it gets a little bit confusing using origins and insertions, but they are the more classic term, so it's totally fine to use origin and insertion, no problem there. As I say, I just tend to use proximal and distal because the proximal the proximal attachment and the distal attachment never change. Proximal will always be the attachment closest to the trunk, and distal will always be the attachment furthest away from the trunk. But you do you. You choose whichever you prefer, whatever you're most comfortable with, go with it. Okay? So, skeletal muscles tend to have a muscle belly. Here we go. Here's a muscle belly. With this example that we're using here is the biceps brachii muscle. It has 2 proximal attachments and it has 1 distal attachment. Sort of. 1 main distal attachment. So, and it's kind of that classic sort of muscle shape. So it's a good example here. It has a muscle belly, and then its attachments are actually made of tendon. So the muscle belly kind of thins out, and the muscle fibers are replaced by tendon, and it's actually the tendon that attaches to the bone. This isn't always the case, but it's just a very typical pattern of skeletal muscles through the body. So the muscle fibers, or muscle cells, are all bound together in groups, and surrounding these groups you have very loose areolar tissue. So if you remember back from when we were talking about different types of tissues, areolar tissue was a loose connective tissue, and we call it epimysium. And then they're also arranged either in a parallel fashion or an oblique fashion to the long axis, or the line of pull if you wish. So an example of a parallel arranged muscle fibers is shown here with rectus abdominis, or an example of an obliquely arranged skeletal muscle would be rectus femoris, or this one here. So the arrangement of these muscle fibers, whether they're parallel or oblique to the long axis, actually affects the degree of movement that that particular muscle can produce. So because a muscle can shorten by around 1/3 of their resting length, okay, parallel muscles produce a higher degree of movement in comparison to the oblique muscles. So you might think they're better, but it's not always the case. It depends on what the function of that particular part of the body is. So all the muscles that have fibers that are running obliquely, we call pennate muscles. So they're feather-like, and you can kind of see, particularly on the bipennate example here, the rectus femoris example, you can see this tendon running up the middle, and then you have the muscle fibers coming in at an angle to attach to the tendon in the center, and it does kind of take on a feather-like appearance. So that's where we get the term pennate from. So we have different type of pennate muscles. You can have unipennate, so essentially you have a tendon that runs up the side of the muscle, and then you have the muscle fibres running down to converge onto that tendon. But the muscle fibres only come from one side, hence why it's unipennate. So an example of this would be one of the interosseous muscles of your palm. That's a nice example of a unipennate muscle. Another example would be extensor digitorum longus, something like that. All muscles that we'll come across throughout the semester, so don't worry about knowing all the muscle names right now. There are a lot, and we will break them down into sections for you, so you don't have to learn everything at once. Then bipennate, as I already mentioned, has this central sort of tendon, and then coming from two sides you have obliquely orientated muscle fibres coming to attach onto that tendon. So a nice example of a bipennate muscle is the rectus femoris muscle, one of your quadriceps muscles in your thigh. And then you can also have a multipennate, where essentially you have lots of bipennate and unipennate muscles potentially coming together to converge on one tendon that will then attach to the bone. So we call that multipennate, and a really lovely example of a multipennate muscle is the deltoid that sits on your shoulder. So if you put your hand on your shoulder, you essentially have your hand over your deltoid muscle. So the important thing to remember about pennate muscles, so there are far more muscle fibres in any given volume than there would be in a parallel muscle arrangement. So pennate muscles, or obliquely orientated muscles, tend to be more powerful than muscles that have a parallel arrangement. So essentially, you're sacrificing some range of movement for strength. That's essentially what happens. And then circular muscles. So circular muscles essentially wrap themselves around a particular area in a circular fashion, as the name suggests, and they tend to form kind of sphincter muscles. So an example of that would be, which is shown nicely here, your orbicularis oculi. So when you close your eyes, and then if you really screw up your eyes, that's your orbicularis oculi muscle that's doing that. If you also have one that surrounds your mouth, your orbicularis oris muscle, again a circular muscle that surrounds your mouth, forming a sphincter. So when you like pucker up your lips, then it is your orbicularis oris muscle, a circular muscle that is creating that movement. So you might want to, at this point, it's up to you, pause the video and have a go at naming some of these muscle shapes. That's fine. Just become familiar with different types of muscle shapes. Are they parallel? Are they pennate? If they're pennate, what type of pennate muscle are they? Unipennate, bipennate, multipennate? Are they a circular muscle, etc., etc.? That's up to you. Have a go if you wish. And with that said, I'm going to end it there.